All right, hey everybody, we are going to do chapter 10 now, which are our ophthalmic agents. There's a lot of information in this chapter, so we'll get going. First, we're going to do a little bit of intro and anatomy. There's quite a bit. Each eye is attached to the cranial nerves 3, 4, and 6, and they're surrounded by several muscles, including the medial, lateral, superior, and inferior rectus muscles, and the inferior and superior oblique muscles. Accessory structures include eyebrows, eyelids, eyelashes, and the lacrimal system. We also have the conjunctiva. This is a thin, transparent membrane that lines the inside of the eyelids and the anterior surface of the eyeball, which you will also hear referred to as the globe. Okay, moving on, we have the sclera. This is the fibrous outer coat composed of dense white connective tissue. This gives shape, provides protection, and can be seen as the white of the eye. The cornea is a clear, non-vascular, fibrous tissue. It receives nourishment from the aqueous humor and oxygen, and it serves as the window of the eye. Then we have the choroid. The choroid is anterior and thickest part of the choroid is called the ciliary body. This is what secretes the aqueous humor from the structures called ciliary processes. And the ciliary muscle attaches to the lens and adjusts the size of it for near or far sight. The iris is attached to the ciliary process and positioned between the cornea and the lens. It separates the anterior and posterior chambers. This is the pigmented part of the eye that gives it its color. And it consists of radial and circular muscle fibers that change the size of its opening, which is called the pupil. So the pupil regulates the amount of light coming into the eye, and it constricts or dilates autonomically. The retina is the nervous layer of the eye, present only posteriorly, and it covers the choroid. Then we have our rods and cones. These are our sensory receptors. They're triggered by images that are focused onto the retina, and they send a signal via the optic nerve to the occipital lobe of the brain. The lens is positioned just behind the iris, focuses images onto the retina. Consists of protein fibers that are arranged in layers. It's normally transparent, and it's covered by a clear fibrous capsule, and it's held in place by suspensory ligaments called the zonula. Okay, the interior portion of the globe consists of two cavities that are separated by the lens. The anterior cavity is further separated into two chambers. The anterior chamber is posterior to the cornea and anterior to the iris, and the posterior chamber is behind the iris but anterior to the lens. The entire anterior cavity is filled with aqueous humor. It flows forward and it drains into the Schlemm canal. Now, if a blockage occurs in the trabecular meshwork, then intraocular pressure, that is what IOP is, builds up, causing glaucoma, which is a group of kind of ocular conditions that are characterized by that increased ocular pressure. The posterior cavity between the lens and retina is filled with a thick vitreous humor. Vitreous humor gives the globe its shape. It keeps the retina in position, and it also contributes to intraocular pressure. So unlike the aqueous humor, vitreous humor is not normally replaced by or naturally replaced by the body. Okay, the blood-eye barrier prevents effective absorption of most systemically administered meds. And the most common administration route for ophthalmic is the topical application. So our drops, suspensions, ointments. There are also medicated discs and pledgets. Agents administered topically enter the system through conjunctival vessels and nasolacrimal system. Approximately 80% of eye drops enter the nasolacrimal system. They drain from the nose into the mouth, and then they enter the stomach for absorption. So compression of the lacrimal sac post-administration helps to prevent that rapid drainage of the meds into that lacrimal system where it's carried away from the eye. Okay, sustained release delivery systems help overcome that lacrimal medication dilution. So we have wafer-thin discs that are placed into the lower conjunctival sac, and they deliver medication every hour for 7 days. An example of that is the pilocarpine ophthalmic or SUR200. Okay, Duracite is binds drug molecules in a matrix that releases the medication in a gel-like drop. It's combined with azithromycin and extends the length of time from the medication that the medication is in contact with the ocular surface. This is used to treat blepharitis, which is inflammation of the eyelids. Okay, the use of pledgets is another preoperative way of instilling medications. It's placed in the conjunctival cul-de-sac after the eye has been anesthetized. So example is instilling mydriatic or cycloplegic meds pre-op, which we will cover in just a little bit. Okay, antibiotic and local meds can be mixed together, may also be added to the pledgets and inserted with tissue forceps, but we need to note that corneal abrasion and patient discomfort are common with this method. Okay, intraoperatively, medications can be administered directly into the anterior chamber. They have an intracameral administration, systemic effect, and they require methylparaben-free medication, MPF. Then we also have something called nanoparticles. These are microscopic. 1 nanometer equals 1 billionth of a meter, so they're very, very small. They're being used in ophthalmology because they can be used for both passive and active drug targeting, and they can be made to control and sustain the release of the drug to the target tissue. It is under still, though, a lot of scientific research. Okay, let's move on to some ophthalmic prep solutions. First up, we have betadine ophthalmic. This is a 5% prep. It's a sterile dark brown liquid. It's stabilized by glycerin that contains 5% povidone iodine. It's used to prep the ocular region up to and including eyebrows, eyelids, and cheeks, and it can also be used to irrigate. It is a broad spectrum microbicide, and it should be left for 2 minutes after we've prepped, followed by an eye flush with sterile saline. Okay, it's used during procedures as well to cleanse the operative site and moisten the cornea. The most common irrigating solution, however, for ophthalmology is BSS, or balanced salt solution. This is sterile and it's physiologically balanced irrigant. It's packaged in sterile containers of 15 and 30 mLs for topical use. And then it also comes in 250 to 500 milliliter bottles for infusion during phacoemulsification, which is a big fancy word for cataract surgeries. Okay, there's also BSS Plus solution, which is enriched with bicarbonate, dextrose, and glutathione. This one's preservative free, but it must be used within 6 hours of mixing. Okay, during most ophthalmic procedures, the scrub tech will be irrigating the cornea with BSS. You're going to start at the inner corner of the eye, and just periodically we'll put some of that in there and allow the solution to flow out to the corner of the eye. Okay. Lubricants are agents that come in ointment form and are used to moisten and protect the eye. Under general anesthesia, the corneal reflex is absent, so to prevent drying and or damage, a non-ionic lubricant is applied. Lanolin is an alcohol-based, Lacrolube, or there's also polyvinyl alcohol, which is Liquifilm. Most commonly, we are using Lacrolube. One thing to note with using that, though, is that patients will experience blurred vision when waking up, and so care needs to be taken that they don't rub the eyes. The first thing that they're going to want to do, even if they haven't had Lacrolube, is reach up and rub their eyes. They are still under general anesthetic, so they don't necessarily sometimes realize either how strong they are, or they will scratch their eyes not knowing it. Okay, now we have some viscoelastic agents. These are thick, jelly-like substances that are injected into the eye. They're often injected into the anterior chamber during cataract extraction. They keep the chamber expanded, they prevent injury to the surrounding tissue, and it also protects the cornea. They may also be used as a vitreous substitute or a tamponade, which just means compression. They're supplied in pre-measured sterile syringes with blunt tip cannulas, and these should be kept refrigerated until use. Some examples are sodium hyaluronate, which is Vitrax or Provisc, 2% hydroxypropyl methylcellulose, which is Ocucoat, or it can be a combination of sodium chondroitin and sodium hyaluronate, and that is Viscoat. Some side effects of these are transient rise in the intraocular pressure, iritis, and corneal edema and decompensation. Okay, and now we've got some miotics. Excuse me. Medications that constrict the pupil by stimulating the sphincter of the muscle of the iris. These are the miotics. They're frequently used in short-term treatment of glaucoma, and that is because pupil constriction causes that aqueous humor to kind of flow out and away from the eye, and it reduces that intraocular pressure. So that's why we use it for short-term treatment. It may be used intraoperatively when the pupil dilation is required. One example of that would be if we were doing a laser iridectomy. Occasionally, it's used to keep the lens in place after a cataract extraction. It may be administered topically or injected, and there are some side effects to this too, which include eyelid and brow pain, blurred vision, abdominal cramping, and diarrhea. Okay. Acetylcholine chloride is available in a solution of mannitol. It is manufactured as Myochol E. It's used in treatment of chronic open angle and acute glaucoma, as meiosis facilitates the drainage of that aqueous humor. It may be injected during surgery to decrease the IOP, and it facilitates that meiosis. It lasts about 10 minutes. It should be reconstituted immediately before use, so it does need to be reconstituted. Then we have carbachol, which is used topically to reduce IOP and by injection, that's manufactured as Myostat, into the anterior chamber. Pilocarpine hydrochloride is available in 1, 2, and 4% solutions for topical administration. It's available in disc and gel form for sustained release, like we talked about earlier, and it increases flow of the aqueous humor. It's most useful in treating open angle glaucoma. Okay, mydriatics and cycloplegics. These are paralytic agents that are used to dilate the pupil. Both cause mydriasis by paralyzing the sphincter muscle of the iris. Cycloplegics also paralyze the accommodation mechanism, so patients won't be able to see objects very clearly that are near to them for a time. After administration of the lacrimal sac should be compressed for 2 to 3 minutes to avoid that rapid systemic absorption that we talked about. And the common ones are atropine sulfate and phenylephrine. These often are used in you may have had your pupils dilated when you've gone to the eye doctor. That's what they're using here, mydriatics and cycloplegics. Atropine can be used to dilate the pupil for weeks after surgery as needed. The onset is about 30 minutes with a peak onset at 30 to 40 minutes, and it can last 7 to 10 days. Okay, then we also have homatropine hydrobromide. This is similar to atropine, but it does have a faster onset, about 10 to 30 minutes, and it is a shorter duration, only about 2 to 3 days. We also have neosynephrine ophthalmic. This does the same things, but it also acts as a decongestant and a vasoconstrictor. The onset's 30 minutes, and the effects last about 2 to 3 hours. Okay, some of the cycloplegic agents include Pentalair and Midrol. The side effects of these include tachycardia, photophobia, dry mouth, edema, conjunctivitis, and dermatitis. Okay, we can also use lidocaine, 1% MPF. That can be used to dilate the pupils during phacoemulsification or cataract surgery. It is administered by intracameral injection, and it acts as an anesthetic and the mydriatic, so it also has that numbing action to it. Here we have some ophthalmic anti-infectives that we're going to talk about. These are used to treat external ocular infections, and they're also used as prophylaxis for surgery. They include the aminoglycosides, gentamicin, neomycin, and tobramycin. Tobramycin may be combined with dexamethasone and marketed as Tobradex. That gives it a little bit of an anti-inflammatory as well. And neomycin is also available as Neosporin. It's mixed with polymyxin B and bacitracin zinc. It's also known as triple antibiotic ophthalmic ointment. Okay, moving on to some anesthetics. Medications that interfere with normal transmission of pain impulses to the brain. That's what our anesthetics are. Originally, cocaine solution at 1% usually was the initial topical anesthetic for ophthalmology. It's now mostly used in otolaryngology. Our two common anesthetics for ophthalmology are pontocaine and alkaine. Those are both in a 0.5% solution. Onset is fast, under a minute, but the duration is pretty short too, only 10 to 20 minutes. And one thing to remember here is that the patient's blink reflex will be lost for that time. So we need to watch for drying of the eyes. Okay, ophthalmic procedures needing a more extensive area to be blocked will get a retrobulbar or a peribulbar block. So if we're doing a retrobulbar block, the agents are injected near the optic nerve. If it is a peribulbar block, the agents are injected above and below the eye in the soft tissues, and that gives us that more extensive area of numbing. Okay, going on to some anti-glaucoma agents. Normal intraocular pressure on a patient is between 10 and 22 millimeters of mercury, and pressure greater than 25 is considered abnormal. Pressure damages the optic nerve, and when that happens, if it's over a prolonged period of time or it is incredibly severe, it can cause blindness. The most common form of glaucoma is the chronic open angle. The trabecular meshwork can't drain aqueous humor effectively. Angle closure glaucoma is much more rare. Only about 5% of the population that is affected by glaucoma has this particular form. It is a narrow junction between the cornea and iris, and that blocks the flow of that aqueous humor. Surgical intervention for this usually includes a trabeculectomy and iridectomy. All right, carbonic anhydrase, which we spoke about in the last chapter, chapter 8. Carbonic anhydrase inhibitors reduce production of aqueous humor, and it decreases the intraocular pressure as well. So that's where our hormones can come into play in other areas of the body as well. Osmotic diuretics may also be used to treat glaucoma by raising the osmotic pressure of the blood and drawing fluid away from the eye. It may be used immediately before surgery to reduce the pressure, or it might be given during procedures to treat retinal detachment and to aid in the scleral closure. The most common osmotic diuretic used in surgery for ophthalmology is mannitol. In ophthalmology, it is manufactured as Osmetol. Okay, then we have the A androgenics and the B adrenergics. These are drops, and these are usually the third line of defense against glaucoma. These are used in the medical field or setting usually, and not in the surgical setting. Okay, for the anti-inflammatory agents, we have two categories: steroids, which we've talked about before, and non-steroidal anti-inflammatory drugs. You may have heard them called NSAIDs. Okay, the steroids, they're used in surgery to decrease inflammatory response to trauma. They also decrease corneal inflammation. They protect the eye from scarring. And post-operatively, they're used to decrease swelling. They are contraindicated in areas of infection. This is because steroids are non-bactericidal. And when they are applied to areas where infection is present, they can sometimes mask the symptoms that come along with infection, and we could miss them. So they are contraindicated if there's an infection present. They might be administered topical, systemic, periocular, and intravitreal. And the common ones used in surgery are Celestone, Maxidex solution, Decadron ointment and solution, and then prednisolone. So they're pretty much doing the same thing that they've done before. We're using them as a pain relief and anti-inflammatory. Okay, ocular NSAIDs are used to prevent or treat cystoid macular edema, iritis, and conjunctivitis. They're used post-op for inflammation following cataract surgeries, and a common one for the NSAIDs is ketorolac. Okay, and then finally, excuse me, we have the diagnostic stains. Okay, these are used as diagnostic tools in ophthalmology. They're usually instilled topically to diagnose abnormalities of the cornea and also to locate foreign bodies. They may also be used to observe the flow of aqueous humor and to demonstrate lacrimal system dysfunction. They're usually packaged in individually wrapped sterile paper strips. They'll get moistened with a sterile solution and then applied to the anterior surface of the eye, and that is how we activate those staining agents. Okay, so there's just a few to go over of these. Fluorescein sodium is non-toxic. It's water soluble. It's applied to the cornea or the conjunctiva to identify foreign bodies. Those are surrounded by a green ring. It also diagnoses corneal abrasion by staining the damaged or diseased tissue green. Okay, then we have rose bengal and lissamine green. These are primarily used for demarcation of conjunctival epithelium, usually seen in dry eye. This is how we find those tissue abnormalities and diagnose for dry eye. Then we have indocyanine green. This is used for ophthalmic angiography. It's given IV outside of the surgical setting. And this is what we're going to use to diagnose tissues deep into the eye and veins deep into the eye for tumors and any kind of abnormalities in the vessels in the deeper tissues. All right. It should also be noted that this does come in powder form, the indocyanine green, so it does need to be reconstituted before use. And it is contraindicated, or it should be noted that it does contain iodide, so caution needs to be used if we're using it in patients with iodide allergies.